Good evening and welcome to another Back to Basics, a series where we like to take a subject, ask a speaker to strip it back and take you through it step by step. My name is Michael Stevenson. I'm the branch chair of the Glasgow branch, and I'm here with the fantastic support of both the Northern Ireland and Manchester branches to bring you yet another live session. Tonight, we are following up what has been a fantastic 4 weeks with the ever insightful and interesting Jackie Locke. Jackie is the program lead at Glasgow Caledonian University and is joining us for his third time on Back to Basics, so a record number of appearances. Jackie, welcome tonight and welcome back to the show.
Thank you, Michael. Good to be here.
For those of you that have joined us over the last couple of weeks, Jackie has been taking us for our annual online LA update. For those of you that have enjoyed that, thank you for joining, and we really appreciate you taking your time to do your LA update with us. For those of you that are just joining in tonight, welcome. And for everybody that's around, we have an opportunity to win what is a perennial favorite whenever we talk about LA or injections, but it is a recommendation that comes through time and time again. So we've got a copy of Ian Riley's and Stuart Metcalf's foot and ankle injection techniques up for grabs. So if you're interested and you want to win a copy of that, something to add to your library, just say hello in the comments. And at the end of this, we'll be doing a wee draw for you to be able to chance to win it. So, you're not here to listen to me. You're here to listen to Jackie taking us through an aspect which you first introduced at the Scottish One Day Conference last year. And I know it's something you really wanted a bit more time to expand on, Jackie, which was looking at nail surgery in the high-risk foot.
Yeah.
Well, I won't hold you back any further. I shall pass you over to Jackie. And as always, your questions are welcome. Do pop them in the comments and we'll keep an eye out. Otherwise, Jackie, over to you.
Thank you, Michael. Welcome, everyone. Unfortunately, I can't see you. I have no idea who is on or how many are on, but welcome indeed to this Back to Basics. I didn't realise I was a record holder being on this for my third time. I think that must be the first record I have ever held in my life, so it's good to have one record to my name. And the topic for this evening, as Michael has said, is considering the high-risk patient in nail surgery. And it does come off the back of a presentation that I did at the Scottish One Day Conference back in May. I was asked to talk about three things. I was asked to talk about the change to maximum safe dose of mepivacaine, to talk about the change to usage of phenol, and to talk about high-risk patients in nail surgery. And I think I spent far too long on the first two, and I had really just to whistle through some of the things I wanted to say about nail surgery in the high-risk patient. And so at the conference, Michael had said, well, you could do a Back to Basics on that for us. So I'm delighted to be able to do this Back to Basics this evening. Just for a bit of context, my interest in the high-risk patient and nail surgery has really developed over probably about 15 years or so. I worked at the Queen Elizabeth University Hospital, and way back at the beginning it was still the Southern General Hospital, and a fantastic department of podiatry there, and excellent facilities too. And it became the end point of many referrals which needed to be done, or people wanted them to be done in a hospital setting. And across our door and into our clinic, there came many complex and many high-risk cases. And the team there, because what I'm going to speak to you about tonight is not all my doing. It is I suppose the end point of many discussions and many hours with the wider team over many years in the Queen Elizabeth. And the philosophy was, if we don't treat them, if we don't do something, then who will? And we worked with a philosophy of finding a way to do something to help the patient, rather than not do anything to help the patient. And it was quite a journey, some very, very interesting debates and conversations about patients, high-risk patients, being referred for nail surgery. Now, I just need to contextualise what I'm going to say a little bit, because I am this evening speaking about the phenolization technique. It's the technique that I learned as a student. It's the technique that is used in NHS Greater Glasgow and Clyde, where I worked at the Department of Podiatry for a number of years, and where I now have an honorary contract. So that is the technique that we use, and it is the most commonly used technique amongst podiatrists in general. Now, there is a suggestion, and I think it's worth considering, that podiatrists are not experts in nail surgery because podiatrists mainly are limited to chemical techniques, phenol being most commonly used, sodium hydroxide being another chemical technique. And whilst we would have to concede that podiatrists generally are not skilled in incisional surgical techniques, I would certainly advocate that podiatrists are the experts in specific chemical techniques. But of course, that expertise can be further developed. And for anyone who is on this evening and wishes to develop their nail surgery skills, I do point you to a course that is available, or I think maybe it's in the middle of being available at the moment. I think maybe the first one is still running. I'm not sure if there'll be a second one. But it is a skin surgery module. It's running over 22-23. The delegates that are on it, I think, are due to conclude probably in June 23. And it's 100 hours of study. And it does deal and it does present opportunities to learn some other techniques. So I use that in the background as context for what I'm talking about this evening, and pointing in that direction for any who would wish to go down that route of further developing clinical skills in nail surgery techniques. But in dealing with the high-risk patient, we do need to understand a little bit about risk management, because many people think that risk management is about creating barriers to stop you doing something, and it isn't about that at all. I've got the definition there. Risk management is the identification, assessment, and prioritization of risks, followed by coordinated and economical application of resources to minimize, monitor, and control the probability and or impact of unfortunate events. So it's about doing something, having considered all the options and outcomes, and doing something in a way that mitigates and minimizes the potential for unfortunate events. Now, I will caveat what I'm going to say about risk management this evening in that whilst I am not an expert in risk management, my wife is, and so she has pointed me in the direction of a lot of risk management techniques. So that is a recognised risk management definition, and there are various attitudes to risk that are recognised. One is the risk seeker, where the benefits and opportunities of something overshadow the risks. And then at the opposite end of the extreme, there is the risk averse, where the risks actually overshadow the benefits and opportunities. And then thirdly, there is the risk tolerant person, one who considers the risks and ensures that something can happen within the safest parameters to reach the best outcome. So our risk seeker is this person here, the base jumper, the cliff diver, etc. Someone who often has disregard for the potential outcomes. Someone who has a can do it, so I will do it attitude. And of course, when we look at things like, I suppose, base jumping and cliff diving, well, I suppose the buzz and the thrill of doing it is all made good when you land safely at your desired destination. The picture on the left is of Pulpit Rock in Norway. I was in Norway during the summer, and I ventured to Pulpit Rock, but only from the fjord below to look up to it, not from the top. So I think in life you kind of get a little insight into where I am. I would struggle to stand on Pulpit Rock, never mind jump off it. Although I have stood at the top of skyscrapers in Far East Asia and China, and I was okay with that. But again, I'm certainly not going to jump off it. So we've got the risk seeker. I can do it, so I will do it. Now, I suppose that is not an attitude that we want, and not an attitude that is advisable in any surgical situation, regardless of discipline and speciality. I can do because I will do because I can do is not necessarily what is required in facing big decisions in advising patients. But then at the opposite end of the scale, we have the risk averse, the exact opposite of the risk seeker, who often places disproportionate emphasis on the potential risks and outcomes. It's like the example, if you go to Disneyland, you'll get the person who is just a bit too scared to go on anything. Even the It's a Small World ride. I'm not going to sing the tune. That is just something I don't want you to have in your head for the rest of the evening. But that type of person is great to go to Disneyland with, because it means you've always got someone to look after the bags when you go away and enjoy yourself in all the roller coasters and other rides. And that person often misses opportunities. And maybe at that end of the spectrum, it doesn't really bode well or suit as well for dealing with high-risk patients either. And what we want to be is somewhere in the middle, the risk-tolerant person, one who considers the risks, and they ensure that something can happen within the safest parameters to reach the best outcome. So if we keep that context as background when we come to think of nail surgery just over the next few minutes. But I suppose to understand nail surgery and the risks and the benefits, we need to actually find out what we know about nail surgery. Well, we know that there are various techniques. There are what would be described as surgical techniques or incisional techniques, the Zadex and the Winograd being two prime examples of incisional surgical techniques. And then there are chemical techniques, phenol, as we're alluding to this evening, and then sodium hydroxide that some or many, I don't know, may use routinely in your procedure. And then there are other less commonly used techniques such as liquid nitrogen and carbon dioxide laser. But we do know from literature that phenol is the most commonly used method for ablation of the nail bed in nail surgery techniques. So what else do we know? Well, we know that phenol works. We know from the literature that it has a better success rate than incisional techniques. It's got a better success rate than liquid nitrogen and CO2 laser techniques. There are limited studies in its comparison with sodium hydroxide, but the evidence shows that it is relatively equitable in outcome with sodium hydroxide. The success rate of phenol in studies is between 92% and 98%. And in local audits that were done in Glasgow a number of years ago, success rates range between 93.9 and 98% success rates. So we know that phenol's good. We know that it works. But that does need to be contextualized, because the first question we have to ask, well, is what is the definition of success? Because we're saying in the previous slide that it's got success rates of 92 to 98%, and in local audits, 94 to 98%. So how do we define success? Well, when you look to the literature, the primary outcome in studies is predominantly permanency of nail removal. That's how success is measured. Did the nail regrow or did it not? Was it a permanent removal or was there any regrowth? So that's the definition and that's the measure of success. And so if we look at 92 to 98% success, I suppose that is a good outcome because the nail is being removed permanently in over 90% of cases. Well, what do we know about the procedures? Well, in the literature, we know that studies looking at success of nail surgery and various techniques, they allude to fairly standardized procedures. The standardized procedure of generally being given the local anesthesia, putting a tourniquet on, removing the nail, 3 to 4 minutes fenal time, although there were some studies that had longer fenal time and some that had fenal time of less, with very good success. We put a post-op dressing on and we discharge the patient. Sometimes we see them back, sometimes the patient looks after their own dressings, but their regrowth is monitored, and that is how success is measured. So we know that success is in the literature about permanency of nail removal, and we know that the procedures are fairly standardized in their process and in their finalization times. But I think there are some key other questions that we need to ask about what we know about nail surgery, and that is what type of patient. And the literature really is about patients who are low risk. And if you read the inclusion and exclusion criteria, you'll discover that patients with systemic, vascular, neurological and pharmacological complexities, they are excluded from such studies. Now, these are the patients that we more and more are seeing and being referred to nail surgery. So it's not necessarily just aligning with all the patients that we see. So these patient types, we know that they are low risk, good health, very little morbidity associated with them. What are the associated risks? Well, we know that with fenal, wound healing, circa 8 weeks. We know that some people heal in slightly less time than that, some will take a bit more, but we know that it is a prolonged wound healing time, and we know that with fenal there is going to be an increased risk of post-operative infection. So what do we know? Let me summarize what we know in the next slide. We know that success is permanent removal of the nail plate using a standard procedure in a low-risk patient who has no systemic, vascular, neurological or pharmacological complexities. That's how success, I think, in nail surgery is defined. But what about the patient who is high risk? We can't really use that measure of success because these people have been excluded from the studies, the people with systemic disease, and the people with vascular risk, the people who are immunocompromised, the people who have pharmacological complexities. So when that patient comes through our door, and when that patient needs us to intervene, what do we do? How do we address that situation? Well, I am back to my wife's terminology to help us with this, and there are 3 options. We can terminate, we can transfer, or we can treat. And so the first thing that we can consider is to terminate. we can do nothing. We don't intervene at all. We send the patient away. The patient leaves with the same risks as they come in, and the patient leaves with the same problem as they come in with. Actually, arguably, I would suggest that the patient leaves us with greater risks than they came in with, because they've seen the health professional, and they've had the advice, they have been sent away with nothing getting done, but the problem still remains. And the likelihood is that they're less likely to seek further advice. It probably reduces the chances of them seeking further advice. And so terminating the discussion doesn't necessarily resolve the problem, because the patient leaves with the problem, and the patient leaves with at least the same risks, if not higher risks, because a professional has sent them away doing nothing. And then there's the option to transfer. And I would suggest that is very often, not always, but very often, an appropriate course of action. Perhaps the transfer might be to an appropriate podiatry centre. Perhaps you feel that the patient needs to be managed in, or the surgery undertaken in an environment where there is appropriate hospital support. And I suggest that that referral, that transfer of risk into the appropriate centre shouldn't be based on an individual's technical skill, because we should have the technical skills to perform surgery. It shouldn't be about clinical knowledge or decision making, because we should be able to work through that. But it can be, and appropriately could be, to ensure that the available support that's required matches the risk and the needs of the patient. I think of one example that if I've got time, I'll allude to later, and that is, for example, a patient with haemophilia, who would certainly benefit from being managed in a hospital environment rather than in a small private area, or indeed a more remote NHS area. So that's one thing that we can consider in transferring. The other is to send to a GP or to outpatient surgery. But we know, and the data again is based on low risk patients here, but even comparing those outcomes in low risk patients with outcomes in podiatry interventions in low risk patients, the success rates don't measure up. GP growth rates in studies equate to about 34%, general surgical regrowth rates equate to about 50%. And again, as well as just regrowth rates, we know that referrals to those professionals, the patient satisfaction rate greatly reduces. Now, those are the data from literature. It's not being critical of those professions. It's not their area of expertise. It's not something that they're doing all the time. So it's not surprising that we have those outcomes in that context. There is, of course, the option for podiatric surgeon referral, but I'm speaking from someone north of the border, where there is minimal opportunity to do that in Scotland. So it's not really a viable option to transfer that route in Scotland. So there are opportunities, and there are moments when transfer of risk is absolutely and wholly appropriate. But then there's a third one. There is treat. That is what we do if we are intervening with this patient. But there are things that we need to consider in a high-risk patient. And I've got them there. Can we alter the patient risk? Can we alter the procedure? Can we alter the proposed outcome? So let's work our way through those three. Can we alter the patient risk? Well, we can, but there's not great opportunity to influence. And probably the one area where there's potential to minimise the patient risk is related to the pharmacology of the patient. Let me just give you a couple of examples. So, for example, a patient who is in warfarin, we have to bear in mind that the risks are very minimal with warfarin. We know we can get prolonged bleeding, but unless we're working with an INR of 5 or over, it's not going to have major clinical significance. But we know that someone in warfarin is more likely to bleed for longer. Now, can that risk be reduced? Well, yes, it can, because the coagulation nurses can work with the patient and reduce their INR to their lowest safe INR level for people to carry out the surgery. And then after the surgery, the dose can be altered to bring their INR back to a higher level. So there is opportunity in that context. Some immunosuppressant drugs, depending on what the patient is on them for. And I think of some of the serious drugs that many people with various inflammatory arthropathies are on. Could they be altered and could they be reduced to minimise the risk of infection? Well, yes, of course they could. Working in conjunction with the rheumatology consultant, it is possible to alter the pharmacology on a temporary basis to minimise the risk, to allow the patient to be attended to and the nail surgery done appropriately. So there are opportunities to alter the patient risk, but they're not that many. And very often the patient risks that we are seeing are the patient risks, and we're not able to influence that. Can we alter the procedure? Well, I suggest yes, we can. Now, we can either think of nail surgery as a single entity, nail surgery, or we can think of nail surgery as a series of component parts, some of which can be used, but others may not be used. So we've got this idea that we can actually think of the component parts of our nail surgery. Are we thinking of it just as, well, I'm going to do a total or a partial with phenol? Or can we start to think of it, well, actually, let's think of what we do. We use a tourniquet. Do we always need to use a tourniquet? If we are, when do we need to use a tourniquet? In the higher risk patient, we've got to remove the nail, but do we need to phenolize? So we don't have to do the procedure as a single entity. We can actually think of all the component parts that we have in our toolkit and start to work out why we use them, why we do them, what their purpose is. Can we alter the procedure? Can we alter the outcome? Well, we can minimize the phenol time. But if we minimize the phenol time and put much less phenol on than we normally would, then we know that we are going to reduce the healing time. That's a positive in many high-risk patients. We know that we're going to reduce the infection risk. That's a positive. But we're going to increase the regrowth risk. So we have to consider that. But if we don't phenolize, we know that we are significantly reducing the healing time. We are significantly reducing the infection risk. But we need to accept there's going to be some regrowth. But here's what I think we need to start thinking about, and that is, can we alter the definition of success? Because we are programmed, because of the literature and because of the way that we work, we are programmed to understand that success is permanency of removal. But that's for low-risk patients. And when we come to high-risk patients, I suggest that we can consider another definition of success, and that is reaching the best potential outcome for the individual patient in the context of their risk. So it's the best outcome for the patient in the context of their risk. Now, in summary, and I think I've got time just to look at a few case studies that I've got just to talk them through, and then I'll take questions. But in summary, the principles that we need to apply in decision making in nail surgery in the high risk patient. When the need arises, the patient risk, the procedure, and or the outcome can potentially be altered to ensure the best outcome for the patient. And we can work towards the best benefit for the patient in the context of given risk. Now, I would say always have a full discussion. We should be doing this anyway, but I think very overtly and very much more explicit in high-risk patients. Always have full discussion with the patient of all the options and all the risks and all the benefits, and document that discussion and document the patient responses to that. And then I think another thing that, as we go through the case studies, will become apparent is be willing to consult with other practitioners involved in the patient care and or other specialists who are involved in the patient care and can offer advice. I think these are very, very important principles to take and to understand when we are dealing with nail surgery and finalisation with high-risk patients. So let me give you 3 case studies, and I won't take too long to go through them, and then I'll happily take questions at the end. And this is one looking at a patient with a vascular risk. He was a 65-year-old gentleman. He had a broad, thin first nail, very fragile, devitalized skin around the medial sulcus of the hallux. And the nail was like a razor blade. It was so sharp. It was chronically irritating and inflaming the medial sulcus. It was excruciatingly painful. He would cry in the chair, anyone trying to work on this nail. And it was majorly impacting on his lifestyle. He had a very poor arterial supply, less than 0.5 ABPI in the affected limb. And the unaffected limb, well, there was a complication there because it had been previously amputated due to some form of vascular disease. We were never quite entirely sure what the actual vascular disease was with this patient. It was quite complex. So what do we do? Well, we intervened, but the first thing is that it was all done in agreement and in consultation with his vascular consultant. This wasn't us being maverick or irresponsible. This was the end product of a team sitting down and working out what best we could do, discussing that with the vascular consultant and the patient, and putting a plan of action into place. So we anaesthetised it in as little local anaesthesia as we could, because it was a very tight hallux, not a lot of room to get solution in. So we did it on a minimal volume of local anaesthesia. We avulsed the medial aspect of the nail plate, and we didn't apply phenol. And it was a short wound healing time. It minimised the risk of post-op infection. And the patient knew that the nail would likely grow again in 6 to 12 months, and that he may require to have it removed again, but he should have symptomatic relief in the meantime. And the patient was delighted with that potential outcome. He was delighted with that prognosis. While we were doing the surgery, we also tried to open the epinicium somewhat, actually do a little bit of damage to the epinicium, almost to kind of try to instigate a slight gryphosis forming, just to make this nail a little thicker so it wouldn't cut into the sulcus just so much. So 12 months further on, the symptoms recurred. And again, in consultation with the same group of people, we repeated the procedure, but this time we applied a very, very small amount of phenol. It was a very short wound healing time with minimal risk of post-op infection. It was closely monitored. We had this gentleman back frequently to monitor his wound. And again, he was delighted with the potential that it might grow again in 6 to 12 months, and he might have to go through it again. However, 18 months later, after the second removal, the patient was still symptom-free and delighted with the outcome. Now, sadly, the patient passed away from another illness. But essentially, by those two interventions, we gave that patient about 2.5 years of pain-free, symptom-free problems in his leg, where before he was in agony, it was impacting his lifestyle. And so that outcome for that patient, who was incredibly high risk, well, on the measure of the literature, it was a failure because we had regrowth. But for that patient, in his context, it certainly wasn't a failure, because it gave him the best outcome that we could propose in the context of his risk. A second one is a hemorrhagic risk. And it was a patient, a 63-year-old male, with thrombocytopenia. He had a recurring cryptosis with hypergranulation. Tisha, I'm sorry about the way the bullet points have landed in this slide. I missed that when I've been putting it together. So the sentences are kind of a little bit disjointed. Some of them shouldn't have bullet points where they are. So a recurring cryptosis with hypergrant tissue. And if you think of thrombocytopenia, we're at massive risk of bleeding. And if you've got a lot of hypergranulation tissue, and that gets damaged, there's a severe risk in this patient of uncontrolled bleeding just from the hypergran being disturbed. And of course, we know that intervening, there's a severe threat of uncontrolled post-operative bleeding. So if we do nothing, then it's a long-term recurring risk. But of course, if we do something, we know that there's an immediate risk of bleeding as we intervene, but we know that there is long-term potential for relief. So what did we do? Again, sat down and had a discussion, and we contacted the hematologist, and we had a discussion, and again, in consultation with his hematology team, and we made an appointment for 11 o'clock on the day of the surgery. He was coming to us at 11 o'clock. But he was admitted to the haematology ward at 8 o'clock for a platelet infusion and for blood tests to ensure that he had sufficient level of platelets. He was then brought down to the Department of Podiatry for us to remove the nail. And we didn't put a tourniquet on at this point. We gave him his anaesthetic, and we worked incredibly slowly, as gently as we possibly could, to minimise any form of tissue damage where possible. We weren't working against the clock because we didn't have a tourniquet on, so we could take our time and work nice and slowly and gently. And when it came to phenolizing, that was when we applied the tourniquet to create a blood-free environment and to allow the phenol to be as effective as possible. And on completion of the surgery, the porter was waiting to immediately take the patient back to the ward for monitoring in case there was any further bleeding. His post-op dressings were done in conjunction with hematology department, again, to ensure minimal risk of uncontrolled bleeding at post-op dressings. Now, the outcome for this patient was that during the surgery and post-operatively, there was no uncontrolled bleeding. There was no post-op bleeding, and this patient healed normally over a period of time. It was phenolized, and again, a very high level of patient satisfaction. Time's moving on. One more brief case study, and this is about infection risk. Now, there are two things really, I suppose, to consider an infection risk. One is a patient where there are systemic disorders, where the immune system may be severely compromised, and the other is where a patient is taking drugs in which the immune system can be severely compromised. And it's the latter that I'll speak about in this case study. And this has gone back quite a long time ago now, and this was when biologics were relatively new and unknown. But this patient, a female aged 45, had a history of severe psoriatic arthritis, and she was on a biologic, and we know that these drugs can cause major immunosuppression, serious risk of infection, with the absence of clinical indicators of infection. And her left third nail had psoriatic features, and it caused her extreme pain. So again, the intervention, well, we had quite a lot of people involved in this discussion. It was myself and a colleague from the Department of Podiatry who was heavily involved in this patient's treatment and care, consultation with the rheumatology consultant, consultation with the rheumatology nurse, nurse specialist, and also we contacted the bacteriology laboratory because we wanted them to agree that every time this patient was in for a dressing change, we would swab just in case there was an infection that was being suppressed and we were missing. Now, of course, again, this involved extensive discussion with the patient explaining the risks and the benefits. And so we went ahead with the plan to avulse the nail. It was a small nail bed, so we put 30 seconds of phenol application on. And we knew that that was going to shorten the healing time from, had we put, say, a minute on or a minute and a half. But we knew that there was the potential for regrowth because we were using less phenol than we probably normally have used. We knew that there was a likelihood that it could regrow. But again, we were recommending she would possibly have around 12 months symptomatic relief. Her rheumatology consultant and rheumatology nurse specialist had a phased lowering of her biologic drug prior to the procedure. And post-operatively, we had dressing appointments in place for 8 weeks. We were going to see her Monday, Wednesday and Friday. And the rheumatology nurse specialist was going to attend every Friday. We took a bacteriology swab at each visit, and they promised us a quick turnaround. So we went through the procedure as planned. There were no positive bacteriology reports, and there was no infection there. 2 weeks after the operation, or the surgery I should say, she was phased back onto her biologic drug. She was starting to struggle again with more systemic psoriatic arthritic symptoms and problems. And so they were monitoring her wound and felt it was appropriate to rephase her back to her normal levels of biologic drug. Her nail bed healed within 4 weeks. There was no regrowth, and again, a very, very high level of satisfaction. So there are 3 case studies that I've gone through very, very briefly that I hope illustrate some of the theoretical elements that I was talking about earlier, but this idea of changing what success is to meet the risk of the patient. Because there are some patients that in a phenol technique, if we applied phenol, the outcomes would be potentially horrific for the patient in terms of healing time and in terms of infection risk. That could be catastrophic if we wanted to permanently remove the nail plate. But we don't need to work with that measure of success. We can consider success as the best outcome for the individual patient, depending on their situation and their risk. Now, just in conclusion, I'm doing the talking here, but as I've said previously, much of my work was done in partnership initially with David Wiley and with the wider team over a number of years, and still going on currently at the Queen Elizabeth University Hospital in the Department of Podiatry, where we often just debate these high-risk patients and how we best manage them. So I get the opportunity to come on and speak about it, but my experience and my knowledge has been built up through discussion and consultation with many of my respected colleagues in that department over a long number of years. So 40 minutes, Michael had said. I think that is just about 40 minutes that I've spoken for. Thank you very much. And the main references that I have there. Couple of Cochrane reviews, Aitkoff et al. And Rounding and Bloomfield, a very good systematic review from 2003.
Jackie, thank you very much. Extremely comprehensive as always, and I think hopefully thought-provoking for some out there in terms of how we look at nail surgery and essentially what we look at. I noticed you mentioned at the beginning the skin surgery course, which is just finishing its second intake, actually, in fact. And I think from what I remember seeing Ian Riley posting up that it was going to start its third intake for next year in June, July, I think. And having been part of the first intake, Ian echoed a lot of your thoughts there about not just about the cases that we look at, but exactly our approaches to it. And the idea, I think he put quite, and anybody that's seen Ian speak about nail surgery will have heard this before, but you know, if we have one tool in our box, that's and it's a hammer, everything's a nail, whereas actually sometimes having a variety of tools allows us to choose a screwdriver when a screwdriver is appropriate. So for those of you that haven't yet caught up with Ian, it's a great opportunity. I'm going to give you a chance, Jackie, to grab a quick glass of juice. Just a reminder to everybody that is watching, we have a chance talking of Ian Riley and Stuart Metcalf there, an opportunity to win a copy of their fabulous book looking at injection techniques. On the course, we had a lot of people asking about experience and the opportunity to practice that. We are just in the process of confirming, but we are hoping that in June next year in Glasgow, we will be doing a cadaveric session. What we will be doing is giving you a chance to spend a day with cadavers, being able to dissect through those cadavers. And what we will be doing is showing you some injection techniques, allowing you to inject a solution there to do it, and then dissect down to see how close you are to the anatomy and explore it as need be. So if you've never had a chance to do that, having been fortunate enough to do it on a couple of occasions, really highly recommend it. It's a fantastic opportunity to update your CPD, update your anatomy knowledge, and really put it into context. So Jackie will be joining us for that, as well as Ian Riley. And as soon as we have the date, we will be popping that up into the combined branches page. Other things that are coming up just whilst we are here, next week or the 20th, coming up soon, week after next, we have a CPR online course on Wednesday. So if you need your CPR updated, do join us. Again, details on the combined branches page. We've also just put up details for our next online course. We're going to follow the same format. We have the fantastic Dr. George Moncrief, who's going to be joining us to do everything to do with dermoscopy, an introduction. So we will be starting off with a back to basics and then 4 sessions online in the same format as we've done for this LA update. So if you found this useful and you found it good to access, it should be a fantastic session. If you haven't tried dermoscopy yet, again, another highly useful tool there to help and aid you in your clinic, whether that be NHS or private practice. And Dr. George Moncrief, we couldn't have anybody better. A fantastic speaker, and also this morning's skin clinic doctor as well. So if you recognize him from that, then a perfect opportunity to join us. Finally, our last little bit of pieces. If you do have any questions, do pop them in there for you, and we'll go through some of them for you. We do have coming up next month, rather than a back to basics, we have our annual Christmas interbranch quiz, an opportunity to prove your boffins. And again, we're being joined by another legend of this phase and of LA, Ian Riley. We have told him to temper his jokes, so hopefully we'll have an entertaining evening and a chance for everybody to get involved. So if you're in the Glasgow area, we hope to see you in person. We'll be putting on an event to join in, but you can also join online as well. Final little bit on there, because I had a couple of messages from people whilst Jackie was talking there. Is it too late to join the course? No, Jackie's sessions have been recorded, and I've put up a quick link there for people if they do want to join. Those videos and the sessions will be available till the end of the year. So I'll pop that up on the screen now. You can go to that link that's in the comments there, sign up there, and you can get access to the page for the next months. And once you finish catching up on that, you'll then be able to get a certificate of attendance. Remember, this is a mandatory requirement every 3 years as part of the Royal College insurance. Jackie, that's me done a lot of talking, so I apologize. In the meantime, we have some questions. Norman, second year student there, currently studying for a POME exam. Well, best of luck, and I'm really glad you found this useful. We we always love it when we get students on here. So Norman, we wish you all the best in that exam as you come through. Liz, question coming in from you. Agree with the fan discussion. I do apologise, a little bit longer here, so it takes up a bit of the screen here, Jackie. More male nail surgery referrals for other nail pathology and non-infection, non-cryptosis sides around there. In the second case study, Jackie, did you use a tourniquet or tubing type tourniquet? And do you have any preference between the two types?
Oh, yeah, interesting. I think going back to when we did it, it most likely was the elastonet type tourniquet, the Eschmark tourniquet that was used at that point. All the tourniquets we use now in clinic are the tourniquets. If you're asking me what my preference is, Michael, my preference is the Eschmark. I much prefer the Eschmark to the tourniquet. I think you can put the Eschmark on in such a way that spreads the pressure over a greater part of the proximal phalanx than the very thin tourniquet surface area that you've got. But that's just my preference. But I think in the second case, I would be fairly sure we used the tourniquet type. Going back to when we did it, I think it was probably before the I think we would use the Eschmark bandage. I think it was before we started routinely using the tourniquets.
And for those of you that are newly graduate, I think a lot of people are using the tourniquets. It's certainly a skill set that's worth practicing a little bit before you do go in with the patient, and getting a little bit of experience of how to use it. Yeah,
absolutely. It's still like that. Don't use it anymore, but I do occasionally get a bit of elastonet out and just make sure I can still do the skill.
Well, no, elastonet's harder to come by, but there are now the elastic bands, and I have to say a tip that I was given on that was once you've got your IPA and everything sterile, is covering it in the IPA, and that means it doesn't end up sticking so much, and it means that it's a lot easier to be able to do the process through that. Anybody, if you do have questions, please do pop them up. Jackie is here, and I think as we've often found, Jackie, the best questions do come from the audience, the ones that make us think that little bit more about that, and the ability to think about a little bit more in depth some of these procedures. What do you think one of the biggest barriers is to us being a bit more, I say, inventive or possibly a little bit more exploratory around these procedures? Why do you think we are so hesitant to look at these higher risk cases?
I think there's a lot of historical narrative associated with it. I think we go back 40 years or so when local anaesthetics and nail surgery were the remit of podiatrists, when they were handed over from, for example, orthopaedic surgeons, general surgeons, and I think they were handed over with a bit of angst and a bit of finger wagging and a bit of don't do this, don't do this, don't do this. And so I think podiatrists at the time took on this process with a bit of fear and trepidation. And I think so they ultimately only worked on patients that were the safest of the safe. Time has gone on. Knowledge has built, experience has built, and I think that is very helpful in the journey. I think I suppose the emphasis in undergraduate education is not just so much now, perhaps, as it maybe was 40 years ago on technical skills, but there's a greater pendulum swing to clinical decision making and to clinical reasoning, and so I think we have that thought process, and also we are being faced more and more with these higher risk patients, and I think there is the philosophy of if we don't, who does? But I think a key thing is that it's all about people sitting down, having the conversations, sharing knowledge, because I could talk for a long time about lots of things, lots of patients I've seen with complex presentations that require nail surgery. But my clinical thinking round about it and my decision making and advising round about it is not down to me. It's down to a wider shared experience of discussions that I have benefited from, and still go back and consult with the same people. So it's not about an individual, it's about people sharing knowledge and people asking other professions, other medics, and we talked about the haematologists, the rheumatologists, the vascular consultants, who have more knowledge in a specialist area than I do, and they can give their insights. And I think it's accumulating knowledge and skill over a long period of time and a body of people across the profession.
I think you're absolutely right, Jackie, and that's a key point there, is that we often act all too often in isolation there, not everybody, but or two, and being able to reach out to those fellow healthcare professionals that are in charge of a patient's care is really what patient-centered care is about, and it's about getting the best outcome for the patients. And I think one thing we do underestimate often is not just our experience, but also our outcomes on these measures. And when compared to other professionals, they might have a wider understanding in some occasions of the context of the patient's health, but still in terms of carrying out the procedure, as you said quite eloquently within the presentation there, we are probably still best placed to do the process itself.
Yeah.
Question coming in there from Andrew Dugan. Andrew, thank you very much for your question. Please do pop up your questions. As I say, they always make these sessions the more interactive, and they're here for you. Would you consider nail surgery for patients undergoing cancer treatments?
Well, interesting, because one of the case studies I was going to use tonight, but I didn't use, was indeed a patient who was undergoing cancer treatment. Now, I don't think there's an easy yes or no answer to that, because obviously every type of cancer is different, every treatment's different. So, for example, if you were asking me if I would do nail surgery on someone who is receiving brachytherapy for prostate cancer, against would I do some nail surgery on someone who is receiving chemotherapy for breast cancer, I think the answers and the consideration are going to be completely different. So I think, again, it's a wider discussion, and it's certainly something that you would be wanting to have a discussion, I would think, with the oncologist as well, involved in patient care. But let me just briefly give you the example that I was going to use. It was a young lady who had been having treatment for cervical cancer. I think she was in her 20s or 30s, I can't quite recall. She had finished her chemo, and she was recovering quite well, but she was going back, I think in about about a month or 6 weeks, I can't quite remember the detail, but she was going back for another consultation. And there was the possibility that if that consultation, if the prognosis from her first round of chemo had not worked as well as they had hoped, then there was the chance that she could be undergoing more chemo. So as it stood on the day of the consultation, when she came in, she had finished her chemo, she was doing well, her bloods were good, they were not concerned, her white blood cell count was good, and she had no further chemo planned. But just knowing that that appointment was coming up a few weeks down the line and there was the potential to undergo more chemo, did I want to do an intervention that created a long-lasting wound that potentially could delay chemo for something far, far more serious than a nail problem? Now, it wasn't, as I recall, it wasn't a cryptosis. It was a non-invasive nail problem. So we had the discussion and we agreed that and she was quite happy with that, that we weren't going to do it because we didn't want to have a problem whereby she actually couldn't get further chemo if she needed it. So I think that's the type of discussion that needs to be had, Andrew. And I think depending on the type of cancer, depending on where they are in treatment, I think it has to be a much wider discussion with the oncology team rather than intervening just on our own basis. If that answers your question.
I think a very sensible approach there, Jackie, and one that again reiterates the importance of that multidisciplinary team approach there. Question coming in from Graham Franklin, and I know one that I know Ian's answer to this one here, but Graham asking regarding hypergranulation tissue, do you promote sharp dissection for faster healing, Jackie?
It's not something I routinely do. I have done it. It's not something I routinely do. I tell you why. And this is anecdotal, so I'm not citing evidence here, that this is anecdotal. But my experience is that when I take hypergran away with a scalpel, then it increases the risk of bleeding once the tourniquet comes off. So it increases the risk of post-op bleeding. And we know that post-op bleeding into a wound probably reduces the efficacy of the phenol. So by doing that to get a risk or an outcome of potentially quicker healing, I suppose we are creating the risk of maybe minimising or reducing the impact of the phenol. So it's a bit of a balancing situation. So I generally tend not to. What I might sometimes do is sometimes you get horrible kind of almost callousy skin kind of round about and overlying the hypergran. I would sometimes just take that away with the forceps, peel that off. Again, I suppose other things that might impact on it. Has there been a raging infection? Are you creating a shelf, believing the hypergran for infection to grow? All these types of things. So there's a lot of things to consider in the individual patient. But in the main, I don't tend to remove the hypergran with a sharp.
I'm going to just say from the experience I've had, Jackie, following the skin surgery course and Ian's approach to it, which is a little bit more aggressive around this area of removing sharp dissection. And I think Ian's approach and the way that he's looked at it is to take two. Is it the nail that is the problem with which is causing the injury, or is it the surrounding skin and fibrous tissue that might be in the sulcus that's causing the injury? And so following that, I have been a little bit more aggressive and have to say that yes, it does incur higher bleeding rates, higher hemorrhage around the areas, but so far and very early stages and around without full audit data, haven't seen an increase in regrowth rates when we have done that. So I think it's something that does require a much stronger audit range, but I do understand Ian's approach to that, but I also do understand people's hesitancy as well about that, as we say, our approach being the least possible intervention for the maximum possible gain for the patient. So I think there's a lot more to be said there.
Yeah.
Coming up to there, I'm going to take one more question from there, and
just while you're doing that, can I, because I noticed a couple of people have asked about the references.
Yes.
Is my screen still sharing?
Yes.
It is, right. So people can see that. Okay, that's fine. Thanks.
I tell you what, Jackie, if you can copy and paste that into the private chat for me, and sorry for everybody who's watching there, into that. What I'll do is I will pop it into the comments there so that you can access it there as well. Because sometimes I know with references it can be quite hard to sort of try and.
Okay. I'll stop sharing the screen so I can copy it.
Absolutely.
And I'll put it in the private chat. Yeah, that's
I'll
fine.
put it in the chat there, and that means we can do that. I'm going to take just one more question, and Jared, your point on cold lasers and healing times is interesting, and I think actually a debate about healing times as a whole is something that is possibly one we should be having a look at, because I think there are some different approaches to that around there. But again, with just sticking to the high risk, there was two questions there about which I think bounce off each other quite nicely with regards to vascular patients. And one of those was from Martin Sherman, and asking about the use of toe pressures with vascularly impaired patients. And then also linked to that is considering whether or not you would use IV iloprost pre-surgery with vascular patient to help dilate and improve flow.
No, I haven't routinely taken toe pressures. Would I consider IV iloprost? I haven't done, never used it, no. So it's not something that's come across my radar. But good question. But I can't answer it fully. So sorry about that.
No, Jackie, it's always, you know, some of the best questions, these ones that make you think about something.
Yeah, absolutely.
And have a look. Jackie, I know this is the fifth Wednesday in a row that we have had you here after what has been a long day of teaching. So I'm going to draw a line under the questions there. But thank you to everybody who took the time to jump on and pop those questions up. Well, Jackie just finds me those references there. What I am going to do, though, is take this moment to do the draw and have a look to see who has won a copy of Ian Riley's and Stuart Metcalf's Injection Techniques book. Fabulous book, one that is definitely worthwhile having on your bookshelf. And the winner is Catriona Doyle. Cat, well done, congratulations. Cat, I know we've done some work with before, so I'm very pleased to see that. Cat, well done and congratulations on that. What we will do is, once we've got the presentations, Jackie, is we'll pop them into the description for this video. So if you want to pop back to save you trying to copy them.
I'm struggling to paste into the private chat. It's not working.
Don't worry about it. What we will do, everybody, is we'll put Jackie's into the description for this video once it's finished. So if you pop back, you'll find those references in there and be able to search it through. Jackie, a lot of people saying thank you. As again, you know, this is the third time we've had you, not just on the Back to Basics, but as the LA update. And I can't thank you enough for both your fantastic delivery, but also your approach to questions and making sure that people are able to get the answers. So Jackie, I'm sure I speak for many of those who've been on the course to say a big thank you for again joining us this year, and we look forward to seeing you again in the future.
My pleasure, Michael. Thank you for inviting me.
For everybody else, don't forget, next month we don't have a Back to Basics, but we do have a fabulous inter-branch quiz, a chance to let your hair down a little bit and join a little bit of cross-country fun and see, can somebody topple Oxford, or will Northampton and Derbyshire regain their title, or we have a new person on that list. Don't forget, if you're not around and you need your CPR, that's coming up next week. We've got demoscopy coming up next year. Apart from that, we wish you all the safest of evenings, and thank you so much for joining us on a late Wednesday evening. Have a fantastic night, and thank you once again. Good night.